for this clinical meeting. I shall not waste much time because we are behind the scheduled time. I request Dr. Anirban Mukherjee, second year urology resident of RNT Hospital. You cannot hear? Now it is all right? May I request Dr. Anirban Mukherjee? Now we can. Second year urology resident from RNT Hospital. He will be present on a case of RCC.
So may I start? Yeah. Good afternoon, everyone. My patient, 65-year-old gentleman from Mizoram, a businessman by profession, Hindu by religion, had presented to the OPD with complaints of pain in abdomen for 2 months. The history of presenting illness: the patient was apparently well 2 months back when he developed pain in the left flank, which was insidious onset, gradual progressing. Pain was incident onset, gradual progressing nature. It was dull aching in character, it was non-radiating and had no aggravating features, and used to give relief by some analgesics he used to take. Negative history: there was no history of fever, any LUTS or weight loss, loss of appetite, or any history of passing of stones in urine, no vomiting or hemoptysis, no cough, no low back pain or lower limb swelling, and he also had no history of any trauma. Past history, there was he had no any surgical history, no history of any TB, and no history of any hospital admissions. Personal history, he was a non-vegetarian. He used to smoke. He was a smoker for last 15 years. 1 pack per day he used to smoke. And his bowel and bladder habits were normal. Family history, it was nothing significant. Treatment history: he had history of type 2 diabetes mellitus and was on tablet glimepiride for last 7 years. And he had also history of hypertension, and he was on telmisartan for last 5 years. He also has no history of any allergies. General examination: patient is conscious, cooperative, well-oriented to time, place, and person. He was average build and moderately nourished. His Karnowski score was 90%. He had no pallor, icterus, lymphadenopathy, clubbing, cyanosis, or pedal edema. He was afebrile at the time of examination. Pulse was 72 beats per minute, BP around 130/80. Respiratory rate was 20 per minute. Systemic examination: on abdomen examination, abdomen was scaphoid shape, umbilicus central. Skin over abdomen was normal, no swelling present, no scar marks present. On palpation, abdomen was soft in consistency, no tenderness present, no organomegaly, and the kidney was non-palatable. Percussion: the abdomen was normal, bowel resonance was present. Auscultation: normal IPS was present. On respiratory system examination, there were bilateral normal vesicular breath sounds present. On CVS, S1, S2 present, no murmurs. CNS, patient was conscious oriented, no abnormal any features present. Genital examination was normal, no evidence of any varicocele. On DRE, anal tone was normal, grade 2 prostatomegaly, which was firm, non-tender, and rectal mucosa was mobile. On investigation, his hemoglobin was 11, creatinine was 1.3, PSA 2.3, urine routine and CS was normal. Then we did an USG. USG showed a 6.5 into 4.7 mass in the upper pole on the left kidney, and it showed increased vascularity. Then we proceeded to do CT urogram. CT urogram showed a mass in the left kidney. It was in the upper pole. with features of some necrosis also present. The report showed it was heterogeneous mass which was enhancing in nature arising from the upper and mid pole of left kidney, which was around 6.3 into 6.5 into 8 centimeters. There were prominent vessels seen around mass, and the mass was causing distension of the adjacent calyxes, and it was also abetting the left psoas muscle and quadratus lumborum muscles. CT chest showed no any signs of any metastasis. It was here the emphysematous lung present, and air space opacities with adjacent fibrosis were present. This was an MRI abdomen we did. It showed in T2 imaging, it showed heterogeneous exophytic lesion around 6 centimeter into 7 centimeter in the upper pole of the left kidney. The inferior margin was 2.6 centimeter from collecting system. It showed areas of some hemorrhage and perinephric fat stranding. Left renal vessel and IVC was normal. The image, the clinical staging was the staging was for T2A. There was no lymph node presence, so N0 MX. We did a complete left radical nephrectomy was done for this patient, and the biopsy was clear cell RCC grade 3 with tumor necrosis present, and there were margins were involved and no lymphovascular invasion present. Thank you.
Thank you.
Thank you, sir.
Do you want to ask question? Okay. No, yes, asked first.
Sir, MRI we did because in CT scan the report showed that it was abetting the muscle, posterior muscle wall. So that's why we decided to see if it's any infiltrating the muscles.
Now my question is, what is the advantage of MRI? What are the advantages of MRI in case of RCC?
So
forget about that. Why you have done both? So what are the advantages of doing MRI? There are some specific conditions where you have to do MRI. What are those conditions?
So for MRI, one advantage is we can look for IVC, any thrombus present or not.
If you suspect any IVC involvement.
Yes,
any,
IVC involvement. And then so if on CT, if there is a non-enhancing mass, if it's CT is showing it's indeterminate mass present. If we cannot make out by CT, if it's signs of any malignancy, then we can do an MRI scan. Sir, if the GFR is less than 60 but more than 30, then we can do an MRI scan, but we should not do a CT scan in that case.
So whenever you will give answer, so you have to tell the specific general advantages of MRI over CT, yes, and specific advantages. Then you can give the answer properly. Yes. Any question from floor?
Pregnancy. Sorry, sir. MRI? Sir, yes, sir. Do just as it's a big mass, for the IVC involvement might be present. That's why, sir. And muscle. No, sir. No, it was not.
Come for MRI. You may have all the facilities, all imaging facilities in your institute. That does not mean that you have to go through all the investigations. Okay, you may have PET. Why you have not done PET CT? Why you have not done PET CT in this case?
Because the CT scan showed like there was no like any metastatic features.
The thing is that your approach should be reasonable. No?
Yes.
You may have all the investigation facilities, but that does not mean you will go through all it.
Yes.
How you decided to perform radical nephrectomy over partial nephrectomy? How you decided?
Over, sir? Over partial nephrectomy. Sir, here it was first of all, it's a big tumor, more than 7 centimeter. And it was.
No, you cannot answer like that. You have some
We have,
scientifically
re-
you have to prove that this is the scoring or something else for doing the radical nephrectomy than.
So we can use to differentiate between success of partial nephrectomy. We can calculate the renal score, sir.
What are the different scores?
One is
What is the renal score you have told?
yes, sir.
What is the different scores?
Sir,
Name the different scores.
one is renal. Yes, sir. Nephrometry square. Nephrometry square, sir. Yes, sir.
Names. There are 3 or 4 names.
Yes, sir. Yes, sir.
Okay.
Okay.
So,
Malaida, we have finished 8 minutes.
okay.
So before we move to the next case, what is the message from this presentation? Each one of us should have a message. What is the message of this clinical presentation?
So, so in case of like RCC, as said by you, sir, so the imaging should be, means not all imaging should be done. Like in our cases, we have done also an MRI scan, which was not necessary in this case. So we could have avoided it. And so like when to do a partial nephrectomy and when to do a radical nephrectomy, like what management should we follow? That we have to decide it on. Extraperitoneal flank approach. Yes, sir. So if it's if it's a big mass, then we go transabdominal, sir. Yes, sir. Yes, sir. It's a big mass, sir. But here in our institute, sir, we did a flank approach, sir.
Again, there are specific indications for doing extraperitoneal removal of the mass. What are the indications? There are some specific indications where you can do extraperitoneal than transabdominal or transperitoneal. What are the indications?
So transabdominal we should do if it's a big mass.
Usually transabdominal is done,
Yes.
Intraperitoneal is done.
Yes, sir.
What are the indications for extraperitoneal?
If it's a small renal mass, sir, involving the lower pole, then we can do, sir. Sir.
Malaida, next case.
Oh, next case.
Next participant is Dr. Shahwat Ahmed from India Forest. His case is adult.
Thank you, sir.